Okay, hello everyone. We just started the live. We're going to wait a few minutes until more people can connect. Excellent. Good morning, everyone, or good evening, everyone, depending from which part of the world you are connecting. Here in London, it's coffee time, 8 a.m. So I was just wondering, as more people, I'm seeing more people are connecting, if someone can just give me feedback, write the comments and tell me if they can hear me and see me well, that would be really appreciated. Thank you. Okay, see more people connecting. So we're going to go live with in 2 minutes with Ebonie Rio. We'll be talking about tendons. This is a live chat, so you will be able to interact. You will be able to ask questions, and if you want to. And excellent. Thank you, Ashish, for letting me know, so you can hear me and see me well. So I'm going to, as I see that more people are connecting, I'm going to add our special guest today. Is a very special, famous guest, Ebonie Rio, and she is a postdoc researcher at La Trobe University. She has completed her PhD in tendon pain, and she's one of the main experts in the world about tendons. So it's a real pleasure, real honor having her here today with us, Physioscience International, talking tendons. So I'm going to add it now. Hello, Ebonie, how are you?
Hello, I'm really well. Thank you so much for the invitation.
Thank you very much for sharing your time with us, and good evening. I know it's evening time here in Melbourne. So, let's say that I'll start. I know that lots of people know you already. You are very famous when we talk about tendons. So, but for the people, for the listeners and the viewers that don't know you yet, could you please introduce yourself and tell us a little bit more about who you are and what you do, please?
Sure. So I am a sports physiotherapist. I also do research. In fact, I mainly do research, but I still see patients by choice. I still love being a physiotherapist. So my main job is at La Trobe University, and I research lots of different things, but I have a special interest in pain and the brain, and in particular tendons. Clinically, I work at the Victorian Institute of Sport, and I also have a clinic with Jill, and we like to see people with tendinopathy together. And in COVID times, that's extended to around the world. So we have lots of different telehealth presentations. And I'm also a mum. I've got a 5-year-old and a 7-year-old, and I'm hoping they do not make an appearance, but they might. And yeah, all of those things keep me nice and busy, but nice and balanced.
Very busy, I would say. So I'll go directly in medias res, into the middle of things. And the first question I wanted to ask is basically arise from a lot of confusion that I see among colleagues when we talk about tendon pain. So what are the factors that contribute to tendon pain? Or even better, what doesn't cause tendon pain?
Okay. That's a really good question. It's really complex. If we start with an understanding of probably 2 key things, and the first thing is tendon load, and then the second thing would be tendon pain behaviour, and then from there we can easily move into some of the physiology if you're interested. Yeah. So I think the first thing for people to understand is what causes tendon pain, or what the clinical presentation is that it's related to high tendon load, and high tendon load has to be fast. So it's when we're asking our lower limb tendons, so I'm going to talk about lower limb tendons today, it's when we're asking our lower limb tendons to act like a spring, store energy and release it really quickly. So if you think of an athlete, sprinting down the 100-meter straight, they actually don't contract and relax their gastrocnemius muscle really fast. It's quasi-isometric, and it's their amazing Achilles tendon that acts like a spring. That's how they run so fast. So our tendons are fantastic and allow us to be athletic. So the clinical kind of follow on from that is what causes tendon pain is these very athletic activities. So, you know, jumping for the patellar tendon or really fast change of direction for the patellar tendon, you know, running for the Achilles. We see hamstring tendinopathy in people that run, but also if they, you know, run in that sort of trunk on body position, trunk on leg position. So that brings us to our second load, which is compression. So our first load is tensile and it's got to be quick. Our second load is compression. It's where the tendon's squashed against the bone. So we're all squashing our hamstring tendons at the moment, sitting in front of our computers because we're in hip flexion. The Achilles tendon is squashed as you go into dorsiflexion. And there's lots of other examples around our foot and ankle tendons of different positions. Our third load is when you combine those two. Provocative for a tendon, but also what we need to get people back to. So if we're listening to what causes tendon pain, it would be activities like it hurts when I run, it hurts when I jump, but not, you know, it hurts when I swim, it hurts when I cycle. So that's really important to help you. And the fourth one in particular is that differential diagnosis load, the shear and friction, which is the repetition of the sheath getting irritated over the tendon, but we're not asking our tendon to act like a spring. So these loads are really important to understand, but coupled with tendon pain behaviour, that localised pain with tendon load.
Excellent. Thank you very much. So would you say that inflammation is a cause of tendon pain or not?
It's a good question, and I think there's a lot of debate around the cytokines and the immune cells and inflammatory markers in tendinopathy. And what I'd say to clinicians is leave the debate at the moment for the researchers, because clinically, targeting inflammation is ineffective. So getting people to think about their tendon pain in an inflammatory presentation. So if we're using terms like tendonitis, your patient won't be on board with an active management technique, active management approach. They won't think they need to do an exercise-based rehabilitation. So what I would say is, while there might be inflammatory changes in tendinopathy, we shouldn't manage it clinically like an inflammatory condition, because people will have a really passive approach. They'll think they need to do rest and ice and anti-inflammatories, and we know that's ineffective. So we were recently part of a consensus that talked about using tendinopathy as the predominant term, and that's really important. Don't underestimate that, because terms impact people's expected treatment. There's a great systematic review by Nickel in 2017, and they showed that in lots of different presentations, depending on the term used, affected people's understanding of what they needed to do. So if you described a bone injury as a crack in the bone or a broken bone, you know, 56% of people thought they needed a cast. But if you used a different term for the same injury, you know, 13% of people thought they needed a cast. So for the exact same injury, every time we're speaking to our patients, they're updating their understanding of what they think they need to do about their tendon pain. So if we say tendonitis, they're likely to be really passive, and we know that the best evidence is for exercise. So we need to make sure our language really reflects that as well. So the inflammatory paradigm is not helpful for us at the moment clinically.
Yes, because there is a lot of confusion on the terminology. That is another great point. So you say tendinopathy that's the term. End of story.
Correct. Yes, that's the most recent consensus. That is the term for tendon pain and dysfunction, and really important that we use that term with all of our colleagues and with our patients, and we differentiate it from other terms. Like if we're talking about, Davide, the sheath that I said before with the friction load, so the peritendon, that's a different condition. So it needs a different term because we manage it differently. So making sure we're careful in the words we use is really, really important.
Yes, thank you very much. I'm seeing already a few questions are coming up about the management of tendinopathies, and thank you for throwing this question, guys. We will arrive a little bit later. So, Ebonie, you are famous for your research on tendon neuroplastic training. And you studied a lot about it. Yeah. What happens exactly in the brain cortex of people suffering from tendinopathies?
Okay, so everybody, if you just come with me up to the brain for a second and just remind yourself of a little bit of our anatomy and our structure. So we have our primary motor cortex, which is a strip of neural tissue, and every movement is represented. And how much sort of real estate or area that takes up is related to how much we use it. It's related to injury, pain, disease. So it's plastic, it's modifiable. Now, from this region where all of our movements are represented, we actually control all of those movements. So this primary motor cortex has you represented, your little motor homunculus, which is you basically doing a little backflip in your brain. And there's two kind of components to that motor control or that motor drive. And the way I like to think about it is it's like the accelerator and the brake of a car. So we have what's called corticospinal excitability, that's our accelerator, and we have cortical inhibition, so that's our brake. And everything that we do is actually a balance between those two things, our accelerator and our brake. And we found in people with patellar tendinopathy that there were changes to both their accelerator and their brake. And interestingly, they were both increased. So it's like they had one foot on the accelerator and one foot on the brake. They had a really different pattern, a really different way of actually changing, of actually controlling their leg extension, their quadriceps. Similar things have been shown in the shoulder and the elbow. And so it seems that when we have tendon pain, we have changes to the drive to the muscle. And this was actually, it was correlated with how long you'd have pain, which makes sense when you think about it from a plasticity perspective, that sort of use-dependent change. So the idea behind using neuroscience in rehabilitation was to see whether or not we could optimize current loading. So we know that load is absolutely, the best evidence for tendons when we're not looking to throw out what we know about exercise and just focus on the brain. It's how can we incorporate what we know about the brain and spinal cord into our rehabilitation.
Oh, that's very interesting. So you said there is some evidence for elbow and shoulder. Would you say it can apply to every tendon in the body?
It would seem logical. There's not evidence for other tendons, and part of that is because it can be a little bit difficult with this technique to actually access those tendons. So you think about the calf or the Achilles and the foot, it's actually represented right down sort of in the vertices. So it's difficult to test some of those, but it would seem logical that this would be a consistent thing across different tendons, but we don't have the evidence.
Not yet.
Not yet.
So how come our intervention, our clinical intervention can impact on these changes in cortical level and change this foot on the accelerator and foot on the brake? What can we do to actually target it?
Actually, it's not a huge change from what lots of us are doing. So many of us are giving load-based interventions, and that's really important. And one of the things that we can do to sort of enhance those interventions is to gather some of the techniques that will change your brain and spinal cord. So the example of the one that I used in research is a metronome. So this external paced training at a specific frequency actually does wonderful things for your brain. So it changes your brake and your accelerator. It forces your brain to use lots of different interneurons to connect different areas. So you'll have your auditory cortex, your frontal lobe will be involved. So you actually get this fantastic sort of symphony of activity in your brain. The other thing that it'll do is it will guarantee the best physiological intervention for your muscle, because what we'll do is we'll guarantee our time under tension from an exercise prescription point of view. You know how sometimes our athletes and our patients can race through their rehab a little bit? This forces them to slow down. So we'll get optimal tendon loading, optimal muscle loading, but critically we'll also reset those brake and accelerator sort of changes in our brain. It takes about 4 weeks from what we can see in the research so far. We see changes over 4 weeks.
Yes, it's very interesting because especially when it comes to certain exercise, when patients find a little bit boring, especially the slow one, they tend to rush it to finish it earlier. But having a metronome is a good tactic just to have that cue. And it's something that we can download through quickly through an app on our phone and use with our patients, right?
Yeah, so when we did the research, I just downloaded a free metronome app and just recorded. I just made my own recording for the research where the metronome was playing. It was 60 beats per minute. Yep, 60 beats per minute. It's all in the paper. We included a slightly longer eccentric component than concentric component. The reason for that is your brain really has to plan. If you know you've got 3 seconds to come up and 4 seconds to come down, you've really constrained that movement and you've made it quite skilled. And even though it's, a leg extension, a boring old leg extension, your brain has to work incredibly hard to achieve that and get the correct tempo. So you're not responding to the metronome, actually you're preempting it. So it's actually that rhythmic kind of auditory cue. So, but just with complete and full company disclosure, the app that we've made is on the App Store, about to be available. It's on Android already. So we actually made an app to link the metronome pace training with the visual cues so that it was really easy. Because what happens is, we've been talking about this for a while, but clinicians are busy. So to go away and make your own app, with the metronome and record it for the person, it's just an extra barrier when people are really busy. So this is just a way of trying to make neuroscience kind of inspired exercise really easy for people. But as I said, full disclosure, because if people buy it, I plan on buying an Audi.
Fine. That's fantastic. It's not there yet for Apple, you said it's for Android.
It's just being approved as we speak, so it's really close.
Fantastic, great news.
Yeah.
So a lot of times when I use the metronome with my patients, they ask me if they just can simply count, because sometimes they are at home, they are rushing, just they're not hard to get the phone and put the metronome on. Would you say it makes a difference? It's better to have the metronome, or they can simply count and pace themselves?
Actually, there's a research study that looked at this, and so Mike Luang compared a couple of different conditions and found that it was that the auditory stimulus and the rhythmic nature is really important. So it's not just being focused and it's not just sort of internally counting, it's that you actually change your brain waves in response to the frequency of the noise, and that in fact that's critical, that self-paced strength and just repetition of activity actually doesn't induce plasticity. So the evidence we have at the moment is that it's very important.
Oh, thank you very much for clarifying this. And am I correct if I say that tendon neuroplastic training is different from normal exercises for tendinopathies just for the auditory cues, or is there something else that you do that is different?
The concept of tendon neuroplastic training, I'd like people to think about it. So we did it in the context of the metronome. I'd really like people to think about tendinopathy rehabilitation in terms of how we restore tendon, muscle, kinetic chain and brain, and inherently within that is function. And the reason why I say that is we need to make sure we move away from doing, should we be doing isometrics, or should we be doing heavy slow resistance, or where does eccentric fit? People want one or the other. If we have someone who needs to, recover back to playing basketball or running a marathon or walking around with their kids, it actually doesn't matter what their goal is, but each of those rehabilitation paths look completely different. And we need to make sure we've actually restored function within that. So early on, you might consider, what exercise intervention you choose. You might start with an isotonic and you might be using the metronome, but it's really important we don't stop there. In research, we look at these discrete times, but in clinical practice, we rehabilitate people back to their goal. So you have to think about education and how you progress, skipping or whatever load you need back to that person's rehabilitation. So I think just thinking about the full spectrum, that's what I'd like TNT to be, is just that complete program.
Thank you very much, Ebonie. This is a lot of questions are coming up. There is Anthony's that is saying, if I listen correct, eccentric 4 seconds, concentric 3 seconds. That's right. And then you ask how much load, reps and sets. So load, I would say it depends on the patients. Reps and sets, is there anything that research has seen working better?
Yeah, really good question. So for the leg extension, so for the quadriceps, we would do 3 seconds concentric, 4 eccentric. We do the same for a prone hamstring curl for a hamstring tendinopathy. For the calf, because it's a smaller joint, we actually do 2 seconds concentric, 3 seconds eccentric. And when we're considering load, you're exactly right. It's dependent for the person in front of them. We try where possible to do single leg, but each leg. So remember the wonderful ability of the brain to deliver us cross-education. So that's where you strength train one side and you actually get a transfer of strength to the other side. So Antonis, what I'd like you to do is on their symptomatic side, do whatever load they can do, but on their non-affected side, go as high as you can, go as heavy as they're capable. People think they need to be symmetrical. We need people symmetrical at the end of their rehabilitation, not at the start, and it will actually drag up their tendinopathy side. So load, challenge each side independently and try and do it single leg. In terms of repetitions and sets, again, it depends a little bit on the goal for the athlete. If you're looking for strength and hypertrophy, we would often give 4 lots of 6 to 8, because that gives us the really good time under tension that we're after. If you're going more on endurance, say for the calf, you might be doing, repetitions of body weight only for the calf up around, pushing them up to 30 or 35.
Thank you very much, Ebonie. Thank you very much, Anthony, for asking the question as well. So in case of very acute tendinopathies or quite severe pain, you are suggesting, do you think it's okay to start training the unaffected limb with high load to get a cross effect on the painful one?
Absolutely. In fact, that would be what I would start with. If you have someone who's really sore, just go back to your tendon fundamentals. So your tendon fundamentals are anything static or slow is not provocative for that tendon. So do what they can do on that side with weight and with load, and then on the other side, absolutely get going on your isotonic load, heavy and slow, and you'll get some good transfer. Also, see what you can do to distribute load across the kinetic chain. So to give you an idea, if you have someone with, say, left-sided patellar tendinopathy, your seated calf raise is critical because it's actually your soleus that decelerates your tibia and you'll unload the front of the knee. So you might be doing an isometric or isotonic for the left quadricep, you'd be doing your seated calf on that side. And then on your right side, just getting as much load in as you can, you know, leg extension really heavy, your calf raises, leg press, just loading them right up and just, you know, giving them everything. But understanding tendon load, that's what's critical.
Thank you very much, Ebonie. So isometric contraction still has an important role in, you know, very painful tendinopathies. We could still go with that 5 sets of 45 seconds of isometric contraction.
Yeah, so again, it depends on how you diagnose tendinopathy. I diagnose tendinopathy as a rate of loading condition. So it's the spring type load. I don't diagnose it by palpating a tendon. And the reason for that is, for example, your patellar tendon is very sensitive in patellar tendinopathy, patellofemoral pain, and osteoarthritis. So in fact, you could palpate someone's patellar tendon, and if that's your diagnostic test, you could potentially have any one of those 3 conditions. So it's a sensitive test, but actually it's not specific. People, it's the same with the Achilles. If I squeeze the Achilles tendon, they might have a peritendon condition, a sural nerve irritation, you know, Achilles tendinopathy, but I'd manage each of those 3 differently. So I think it's really important, the converse of someone being provoked by fast loads is that static and slow loads are safe, but it all gets down to how people diagnose tendinopathy, and we don't all diagnose it the same way. So I'm very pragmatic. What I would say to people out there is it's a very safe thing to try. We're not asking people to spend a lot of money. If you ask them to do an exercise, you're not asking them to do anything invasive for the tendon. So if you tried isometric or isotonic load for someone with anterior knee pain and they improve, fantastic, you have a start point. If they don't improve, regardless of what you call it, you need to work out what your next step is, how you change your management in some way. So for me, if someone had increasing pain on a leg extension or an isometric, or they had pain that was more diffuse, I would try a taping technique. I would try something different.
Thank you very much. That's very useful, and our listeners are getting very engaged. So I'm receiving a lot of questions, and if you don't mind, I will throw a couple of them at you. There is Mikalis that is just want to double check if is. So as I understand, if we have, for example, an Achilles tendinopathy in the left foot, you suggest that we continue to load as much as we can the right Achilles. Is that right?
Yes, that is right. So what I would say is if you have someone with a left Achilles tendinopathy, we need to rehabilitate the right at the same time anyway, because we do know the risk of them becoming symptomatic on the right-hand side is increased. So what we need to do is rehabilitate our whole person, but what we can do is progress them on their right side as much as possible. So you might start with, say, a seated calf raise, a standing calf raise, as well as your calf raise endurance on the right, and then on the left you'd be trying to do the same, but the loads might be different.
Thank you very much. And there is another question from Gabriele instead that is asking about tendon neuroplastic training. Do you think it's better to use isolated tendon that is affected, or maybe to just involve the entire kinetic chain, or maybe both?
That is an excellent question. I would suspect that the entire limb is probably affected in some way. That would be my hypothesis. I think this is one of my favourite questions I think I've ever had. Thank you.
Sorry,
we also know.
Sorry, Ebonie, you say involved at the cortical level or at a tendon level?
Well, both actually. Cortical level, definitely. I would hypothesize that the whole kinetic chain is involved in some way cortically. And actually, Gabrielle, we know that we get changes to both hemispheres with a unilateral tendinopathy. So that really implicates why we would do TNT on each side, and that's what the app is. It's for the left and the right leg for that reason, because we actually get bilateral changes with a unilateral tendinopathy. We also know that we have changes at a tendon level on each side, even with a unilaterally painful tendon, that the tendon on the other side is not completely normal, for want of a better word. From a very clinical, pragmatic perspective, though, I don't use the metronome for all of their exercises. And part of this, Davide, gets back to what we're saying about adherence. So what I might do is get them to do their metronome-based training for their affected body part, for their affected muscle tendon unit. And then for the rest of it, I might let them listen to music or whatever it is, because for me, the most important exercise is the one that's done. And so I think it's really important that we meet our patients halfway around what they're likely to do. I have had a football club say, oh, should we just play a metronome over the loudspeaker? And I think that would be horrendous for people to listen to at the gym. So I think it's important to get optimal training as much as you can, but also compromise with your athlete about what they'll actually do. Geez, that's a good question.
Thank you very much for the answer. Lots of questions are coming up. So I would say, talking about instead athletes and how to manage athletes in season, there is a question that comes up from a Facebook user. Let me put it out. He wonders, how do you manage a tendinopathy, maybe an acute tendinopathy as well, in an athlete season? I found it very difficult to change their pain, he says.
It is very difficult. So the first thing I would say is, and I start with this always, make sure you think it's the tendon that's driving symptoms. So really go back to your tendon behavior. So if you have someone with Achilles region pain, ask them if it warms up. Does it warm up, or does it get worse the longer you go? Because you would manage a peritendon condition very differently to a tendinopathy. So the first thing I'd say is just really make sure you have an accurate diagnosis. If you're worried about a peritendon around the Achilles, you know, you can listen with a stethoscope and get them to plantarflex and dorsiflex, see if you can hear the crepitus, so that can distinguish between your tendinopathy and your peritendon condition. The peritendons get worse the longer you go. They're provoked by things like calf raises, which is why it's really important, because if I have someone with tendinopathy, Achilles tendinopathy, you know, I need them to be doing calf raises, but that will provoke a peritendon. So the management's very different. If you have a mixed presentation, you have to deal with the peritendon first. So my top tip in season would be, make sure you're very, very confident of your diagnosis. The second thing would be knowing your tendon loads. So isometric and isotonic are very safe in season. What we have previously done is we've tried to rest people and we've pulled back on load. Actually, they're worse for not having done their gym. They can do their static and slow loads. As I was saying before, optimize around it. So if we're talking about the anterior knee, making sure the calf is fantastic, getting as much calf as you can to absorb the loads and unload the knee. And that's both standing calf and seated calf. The third thing I would say is just make sure you know what load they're doing each day. So we think of our training loads and we know they're high tendon load. We're asking our tendons to store and release energy like a spring. We know our game day load is high load. Just make sure on their gym days, they're not doing additional plyometrics or box jumps or, you know, load that is actually high for the tendon. Because I've sometimes seen programs where, you know, they've got a gym day, but they're also doing lots and lots of plyometrics. Then they have a training day, then they have a gym day, and they have skipping as a warm-up. Well, that's plyometric for your Achilles tendon. That's high tendon load. Then the next day they have training. And before you know it, they're actually doing high tendon load each day. And so knowing how to communicate with your athletes and coaches and strength and conditioning about what is high tendon load. High tendon load is anything fast. We're not talking about things that are heavy, that might be hard for a muscle. So in a gym scenario, just making sure they don't have additional plyometrics. So nail your diagnosis, number one. Number two, optimize through the kinetic chain as best you can. Number three, make sure they're doing static and or slow loads through that muscle tendon unit. And number four, just making sure they're not doing high tendon load, additional high tendon load.
Thank you very much, Ebonie. You are really...
I hope that helps, but in season is hard.
No, really, you are helping us so much, really, so far. It's been fun. Thank you very much. You mentioned this already. You said that there is some research coming up for shoulder and lateral elbow tendinopathy. And there was a user, Yannis, asking if this approach of tendon neuroplastic training can be used with the evidence we have so far, even for upper limb tendinopathies.
I'm going to defer to fantastic upper limb people like Jeremy Lewis and Joe Gibson and Tanya Bazari to answer those. I think the differential diagnosis is really complex. There can be a lot of different things going on. So I don't know that the approach is the same, and I'm definitely not the expert. People like that tell me that they take aspects of lower limb tendon loading and apply it. And I think those people that are experts do that really well. And I'm not the best person to answer that question. Sorry.
No. Thank you, Yannis, anyway, for asking it. And so you mentioned before that you don't use the metronome for every exercise, but even simply listening to some music can have similar effect. Is that right?
It's all about the beat, actually, and the rhythmical nature. So it would make sense that some music would be appropriate, particularly when you consider athletes like dancers that actually need to move, to a beat. It might make sense to pace them using those sort of cues. There is some research that shows that if you try and externally pace very good runners, you actually make them run worse. So we tend to use the external pacing early on in the rehabilitation, in the gym work, but not when they're doing their functional activity. But there could definitely be some pieces of music that would meet the brief.
Thank you very much. And what about visual cues instead? That we talk about auditory cues. Is there anything we can use visually to enhance maybe the cortical changes?
So most of the research that's looked at visual cues have actually looked at it in neurological conditions like Parkinson's. So it's difficult to know how we might translate that into, people without the neurodegenerative conditions. But what I would say is that the connections between the visual cortex and the motor cortex are actually stronger than the auditory cortex. So it does make sense that would be plausible. So for that reason, that's actually why in the app that we made visual cues as well as auditory cues. So right at the start, people answer some basic demographics so that with the idea being that you sort of recognize self. So you're seeing someone, of similar coloring to you, similar accent, because we actually hear at certain frequencies, which is why it's easier to understand and learn some languages between different cultures than others. So you answer some information about, your sex and your ethnicity, so that what you're seeing on screen is like self. And then we have different views. So you might see the bird's eye view just to maintain that interest, but also that visual connection during. But I have a very clever colleague who's looking at doing some research using mirrors to see, if there's some sort of more simple technique we can use.
That's fantastic. Thank you very much for this, Ebonie. I'm speeding it a bit because as I see really lots of questions coming up, and some of them are very good. So actually the question I wanted to ask you is there is we focus a lot on the importance of the biopsychosocial model, and when we go ahead with such selective rehabilitation strategies, the risk that some colleagues may have is that we fall back into the biomedical model of care, focusing too much on the tendon, for example, in this case, and too little on the person and the social context. how do you think we can conciliate the need for a specific training like the tendon neuroplastic training with the biopsychosocial model?
I think it's critical that we're all biopsychosocial, and I think it's critical that we are consistent. And the way we do that is we listen to our patients, we empower our patients, and it's shared decision making. So something that I love from Lorimer Moseley, Professor Lorimer Moseley, are the 4 questions of self-efficacy. So people would like to know, what is wrong with me, for want of a better term? What can you do about it? What can I do about it? And how long will it take? And that's pretty much how I structure my my education with people. And the reason for that is if you take someone with a peritendon condition, okay, and this person's saying to you, it hurts when I do my calf raises, I'm getting worse. You've told me to be physically active, I'm cycling, it's getting worse. The longer I run, the worse it's getting. I'm not getting anywhere. If we're just saying, no, be active, be positive, I mean, we're not listening to them. We're actually not being biopsychosocial, and we're not taking on board what they're saying and actually integrating it into our care. So the biology is important because how we manage tendinopathy is different to peritendinopathy. People are telling us different things. Their management is different. So the education is intimately related to the biology. If you have someone with a superficial bursal irritation on the back of their calcaneus and their footwear is rubbing or compressing, unless you actually deal with that, then the other strategies that we have to improve their sleep or their well-being won't be effective. It actually genuinely has to work together. So I think we can't throw out the biology. I think at times we've all been guilty of the extremes. So I think it's really important to remember that if you're educating someone, that isn't reserved for chronic pain or central sensitization. Education is critical for every patient. If we're assessing people with load-based interventions, asking them where their pain is, trying different load-based interventions to see if it helps them, that's very different to me, putting shockwave on your tendon every week where you're dependent on me for your care. So everything that we can do with someone can either empower them or sort of take that power away. So it's worth keeping that in mind with how you speak about it, but also the interventions that you use.
Thank you very much for the answer. I think that is a great one. And Ashish was asking how, because patients with especially acute tendinopathy sometimes get a little bit confused what is going on, why I'm so much pain, why doesn't it get better after 2 months, and they are irritable and anxious. How do you educate the patient that what they are experiencing is normal? And I would add another little question to Ashish one. Lots of the clients, when they do slow, heavy exercises, they ask me, are you sure it's not going to snap? So how can we answer confidently that question and reassure confidently the person that is all right?
Absolutely. So to borrow a line from David Butler, who was a fantastic pain educator and just brilliant, he reminds us to meet the person at their story. And I think that's the best place to start. So what I might do, Ashish, is I might take their story. I might listen to them as they describe what they've tried and what hasn't worked, and I'll make a little mark as I go for me to make sure that I deal with that as an education point. So I don't have generic information. Everyone gets a sheet. It's what is this person coming to me that they need clarification? Are they really anxious about their imaging? Are they really worried about, it says I've got calcification. Well, then what I might say is actually, if I'm a cell in the body and I experience lots of tensile load, then I'm a tenocyte and I make tendon. If I'm a cell in the body and in my environment, I experience lots of compression, then I'm a chondrocyte and I make cartilage, because our cells are very responsive to the load and the chemical environment. if I'm a cell in the body and I'm undergoing lots of tensile load and compression at the same time, then actually the best tissue we have for withstanding those two forces is bone. So that's why we see calcification within your tendon. It just tells me that your tendon's undergone lots of different loads. It doesn't change my management. You're going to do really well. We don't have to worry about it. And that's quite different to me saying, don't worry about your imaging, or, ooh, that looks bad. So it's really important that we're evidence-based. Everything I just told you was evidence-based, but that we're actually educating our patient in relation to what they need to get out of the consultation. Another good example, Ashish, and this speaks a little bit to your question as well, Davide. I learnt this from Professor Jill Cook, and I really like it, and I'm sure some of you have seen it, but just indulge me a little. This is your capacity, and this is your load. And this is not just tendon, this is the capacity of our musculoskeletal tissue. So this is tendon, bone, muscle, everything we have, use it or lose it. And so what I'll do is I'll take the person through what they've just described to me. So they might say, I was training for a half marathon and I was getting a little bit close to the date. So I increased my kilometers quite a bit. So they increased their load and they might have got pain. And then they thought, oh, my Achilles is a bit sore. I better have a couple of weeks off running. So they drop their load and their capacity drops as well. And then what happens is they try to go back to running because their Achilles is, not too bad. And they have pain again. And they don't understand why, because they don't think they've overloaded. They might have done the same session that they'd done a few weeks ago, but it's overload relative to their new capacity. So what do they think? I haven't rested long enough. So they drop their load again, their capacity drops. They try and run, then no good. They think, oh, it must be quite bad. They might go and have an injection, have a couple of weeks off, and I show them their journey, whatever it is, about the interventions that they've tried, particularly if they're passive, particularly if they've involved a lot of time off, because then you can really explain to people how the only effective intervention for tendons, and there might be adjuncts, but the only effective interventions for addressing tendon, muscle, brain is going to be load-based. So you explain to people that you can gradually, progressively increase their load to build their capacity. When patients are very anxious and very nervous, I really respect that, and I go really slowly with them. I teach them about tendon load. I teach them that anything slow or static is really safe, and we just go really gently. We just meet them at their story. But I would say find out the education points for the person and try and come up with how you can specifically target that. It might be doing the gym session with them. I know we're in lockdown, so that's probably not an option at the moment. It might be them videoing it and sending it to you, but just slowly and making sure you're listening to them.
Thank you very much, Ebonie. So you say that a static load, like an isometric load, is safe even with a very degenerated tendon?
Yes. So a very degenerated tendon, so a tendon with lots of pathology in the Achilles and the patella, thanks to Sean Docking's amazing work, we know that we have this fantastic adaptation. So we have a thicker tendon. That's great. That means we have lots of load-bearing tissue to take the tendon, to take the load, pardon. We also know that there's no relationship between how much degeneration there is and how much pain someone has. There's a complete disconnect between those two things. So you can absolutely, in fact, you'd probably argue that a static load is the safest load to start with if you had someone with a really, poor capacity tendon.
Thank you very much. So what happens when everything fails? There are patients that they don't get better, and maybe they're not compliant with exercise, or simply the exercise are not working for them in that moment of their life. What do you think is the next step forward? What literature says about other type of intervention, like shockwave, PRP, steroid injection, and other, let's say, more passive intervention when everything fails?
I wish we had evidence for a next step. So unfortunately, the evidence is not strong for any of those things. So the first thing I would say is when people have failed, really look at why they've failed. Go back to basics. The people that we see have often been misdiagnosed. So they might have anterior knee pain. So a really classic example, I had an older woman who just wanted to walk, and she was diagnosed with bilateral patellar tendinopathy. Now, you don't get patellar tendinopathy walking around. This is not a woman that uses her patellar tendons like a spring. So it's a misdiagnosis. And that comes from people palpating it and also getting confused by the imaging. So she had changes in her tendon, but we also know that they're load-related changes. She's probably had them since adolescent. So we need to make sure we get our diagnosis right. She'd failed a conservative rehabilitation program for tendinopathy, had multiple interventions into her tendon, spent a lot of time and money. So make sure you check your diagnosis. I see the same thing in the Achilles, where people might have a peritendon issue or, the superficial bursa. And so that's the first thing, get your diagnosis right. The second thing for me is just look at exactly what they did in rehabilitation. So we see some people that have been given, all double leg exercise. Well, the challenge with that is that everything you do as a human, you actually do on one leg at a time, really. So running is a series of hops. So if you only do bilateral exercise, if you only do double leg exercise, as soon as you then expose that tendon to single leg loads, you've actually underloaded them. You've underprepared them. So the conservative rehabilitation that I see that's failed, there's been things about the rehabilitation itself. That's the first thing. And following on from that, actually, is if you just try and use the evidence, it's really difficult to manage tendinopathy. And I'm not saying we shouldn't be evidence-based, we should be, but we can't be recipe-driven. Now, what I mean by that is in research, we try and answer a question. So our question might be, in season for 4 weeks, do people tolerate an isometric quadriceps contraction and an isotonic quadriceps contraction? Now, that's not a full rehabilitation program. That's 4 weeks in season with a really defined question. Similarly with the heavy slow resistance programs, we're asking a question for a finite period of time. If you consider that we know tendons hate change. So if we just give people a strength-based intervention, which is what most of the research is, and then get them back to volleyball, which is jumping 300 times in a session, it's too big a jump. So what you need to do is incorporate the literature of progressive tendon loading. So it might be for the Achilles that we start with our strength, seated calf, standing calf, but you need to incorporate those pulse activities that Craig Purdom talks about, some stair climbs, some skipping, some change of direction. Your rehabilitation looks totally different for a runner than a football player because of the different ways they need to load their tendons. So we need to make sure our rehabilitation is complete. That's the first thing. The next thing for me is I would go with the intervention that has the least risk or consequence. So out of the ones you said, that would be shockwave. Now, shockwave, there is some evidence for and against it, but in terms of being the lowest risk, it's probably the least risk. Cortisone, when people have used it, it actually knocks down cell activity. So the long-acting cortisones, the trouble with them is it means you'll make the tendon sort of deaf for 8 weeks, and then when you reintroduce that load again, it's huge overload. And there's no good evidence in tendinopathy for PRP. There's a big multi-centre trial in patellar tendinopathy. There's a couple in the Achilles. So it's probably a difficult intervention to propose at the moment in terms of having any effect. Probably the last one to mention, if I might, would just be the surgery. So Håkan Alfredsson's pioneered the sort of the filleting technique, where you actually sort of denervate the tendon by scraping away the peritendon and the fat and the sensory nerves. So I've known athletes that have had that done in patella and Achilles and then rehabilitated after that. The biggest challenges that I see are the people that have had too many interventions into their tendon and they now have complex chronic conditions where you're no longer just dealing with the tendon you started with.
So yes, very, very bad potential side effects.
Yeah, that's really hard. Yeah.
So I'm being mindful of the time. We have 5 minutes left. I don't want to steal too much of your time because you've been answering so many questions so far. And I thank you for that. There is one of our listeners, Ioannis, that is asking about any strategic use for deloading. I know that you mentioned something with athletes before about maybe avoiding heavy plyometrics. Any other tip that you think could be useful to help us to just to deload the tendon, not too much and not too little?
Yep. So excellent question. So if you have an element of compression, and often our tendons do, absolutely try and remove the compression. So to give you an example, if we're talking about the Achilles insertion, they're compressed as people go into dorsiflexion, okay? The tendon's squashed against the bone in dorsiflexion. So what you do is try and remove that provocative load by getting your patient in a shoe with a nice high heel, so they're staying right out of compression. It might even be, if they're an athlete, you can actually wedge their boot or their shoe, but really removing the compression, removing any stretching if they're doing it. Attention to detail in their gym program. If they're doing a seated calf raise, making sure their tibia is at 90 degrees and they're not going into dorsiflexion when they're doing their gym work. Same if they're doing a squat. Making sure that you put them in a Smith machine so they do a back squat with a vertical tibia and don't have their knee forward of their ankle, or you might chock something under their heel. So just that attention to detail if you've got compression. If it's a hamstring tendon, making sure they're not doing deadlifts or squats or anything with that compressive element with that hip or trunk flexion, but not complete rest. So in that situation, what you might do is get them to do prone hamstring curl. So you're still doing slow load, but it's out of compression. So removing compression would be my number one tip for your tendons. That would be the first thing. That's a really, really nice one that can give you a lot of symptomatic relief. The next thing would be removing unnecessary or removing additional speed. So sometimes the conversation to have with coaches and athletes are, just say you can jump 300 times a week. Do you want to use up, 290 of those doing exercises in the gym? Or do you want to sort of reserve those for training and games? So if you've only got a certain amount of capacity you can do a week, optimizing how they do that, really thinking about the purpose of the exercise. If you've got someone with Achilles tendinopathy and they need conditioning, can you get it another way? Do they need an additional running session in? So just making sure you're really thoughtful. The next thing for me is thinking about the timing of your load. Tendons like time between load. So it might be that you take their loading for the week and you negotiate where it's structured. And so, it would be getting rid of compression, getting rid of speed if you can, or spreading that stuff out as best you can. But if you've got a really reactive tendon, you have to change something. You have to deload them. It's a really good question in some way.
Thank you very much, Ebonie, for the answer. Ευχαριστώ, Ioannis, for the question. And Ebonie, do we have time for one more question? The last one, I promise.
Of course, no problem.
We're arriving a lot. So...
we should do it again.
Exactly. He's asking if in insertional knee tendinopathy, would you use the same neuroplastic exercise following the same principle? Is there any differences between insertional, non-insertional, or mid-portion, like in for the Achilles, apart from the stresses on the periosteum?
Good question. So the first thing to say is in the the Achilles tendon, we see a mid-portion tendinopathy, but almost all of the rest of our tendinopathies are insertional, as in the Achilles insertion, or they occurred at a bone tendon junction. Another exception would be tib post at the region of compression. So to answer your question, I do use the same principle. The key things that I modify, if we're talking about the patellar tendon, there's a couple of things about the patellar tendon I don't understand. They don't like being completely straight. I don't know why. That makes no sense to me. They hate sitting in the back of the car. So rather than go 0 to 90 on the leg extension, we might go 20 to 80. So it's okay to modify the range. And in fact, I would always modify range first and load second. I try and keep it as heavy as I could and modify the range that they do it in. For the insertion of the Achilles, the critical thing there is keeping them out of compression. Same with tib post. Don't go into dorsiflexion because you'll actually compress around that medial malleolus. So the principles around load and exercise and even the metronome can be used similarly, but the restrictions around the range and the cueing is what I would change in each of those.
Thank you very much, Ebonie. I promise you no more questions after this. You've been fantastic. So how can people interested in you can follow you and your research and your work? How can they contact you should they need to as well?
Yeah, sure. So it's pretty easy to find these days. You can just look people up and you'll find, their email address or whatever you need. In terms of following the research, the La Trobe Sport and Exercise Medicine Research Centre, so LASM, we try and make a lot of our information, our blogs and infographics and everything available for people. So I'd encourage everyone to have a look through the La Trobe website, and we're actually just about to release quite a few videos and infographics on tendon management, so I'll be sure to share them with you and you can send them around. We're just trying to make it really useful. How do you clinically diagnose? How do you differentially diagnose these conditions? What are the features? How do you manage it? Just the absolute, tips and tricks. So I'm looking forward to getting those finished, but we're a little bit delayed with COVID, getting all the videoing and everything done.
Thank you very much, Ebonie, for your time. It's been extremely useful for us listening to your expertise. And I wanted to thank as well all the listeners to spending their time on a Sunday morning or an evening listening and talking about tendons. So thank you very much all for participating. We have other chat coming in December. So if you are interested, if you find these interventions valuable, please just put a like on our Facebook page, Instagram page, Twitter, LinkedIn, and YouTube, and you can be updated with all the talks with our top speakers. So thank you very much all, and thank you, Ebonie, and I wish you all a great Sunday.
Thank you for having me, and thank you everyone for listening.
Bye.